Welcome, and thank you for participating in this accredited activity. You can access the CME information for this activity, including details on how to claim credit via the QR code that appears on your screen or the link that is posted within the chat box. A link to our resource page, which includes all journals we will be discussing today, can also be found in the chat. Today's presentation is the final session of our three-part series, Empowering OB-GYNs, Leading the Way in Postpartum Depression Care. If you are interested in viewing Part 1 and Part 2, please see the link to these activities on our resource page. I would like to introduce our faculty for today's presentation. Dr. Joy Baker is a board-certified obstetrician and gynecologist in LaGrange, Georgia. She currently serves as Director for Quality and Safety for Women's Health and Vice Chair of the Department of OB-GYN and Pediatrics at Wellstar West Georgia Medical Center. Dr. Cipralata is the co-founder of Luna Joy and an adjunct professor of psychiatry at Emory University School of Medicine. She is also a psychiatric consultation line advisor at Postpartum Support International in Brookhaven, Georgia. If you have any questions throughout our session today, please post them in the comments and our presenters will address them at the end of our session. I will now turn this over to Dr. Latta to introduce our journal articles for today's discussion.
Today, we will be discussing two articles as well as some cases that go along with that. The first article here is Models and Key Elements of Integrated Perinatal Mental Health Care, a review. And the second one is a qualitative examination of the implementation of perinatal collaborative care. Before we begin, I am going to ask Dr. Baker to quickly review our first session. Dr. Baker.
Thank you, Dr. Latta. It's such a pleasure to be back with you guys for part 3 of this very interesting conversation, very necessary conversation that we are having. And so for our first session, we talked a lot about routine screening and using validated tools to do that for every patient, every time. Screening at multiple encounters. ACOG does recommend that you screen somewhere early on in the pregnancy, somewhere around the 3rd trimester, and certainly in the postpartum period. So, a good rule of thumb is to screen early and screen often. A positive screen does require a system in place for assessment of that positive screen, intervention, talking to the patient, and sort of finding out where they are, and then determining what you want to do in terms of treatment, whether it's referral or starting treatment on your own in your office if you're comfortable doing that. We definitely don't want to screen folks if we don't have any way to treat them. So it's very important to sort of get together your list of resources when you decide to screen patients. And then in our second session, we talked about recommendations for pharmacologic treatment. And ACOG has recommended that we actively treat perinatal depression and other mood disorders during pregnancy. SSRIs do remain the first line pharmacotherapy for treatment of these mood disorders, and neuroactive steroids can also provide rapid symptom relief and can fill a gap for those patients with moderate to severe postpartum depression. And so the evidence increasingly supports that aggressive treatment of maternal depression to improve outcomes is warranted for both mom and baby. So we now know that there are risks to not treating patients. So these two sessions have been fantastic, and you can go back and review those on the resource page if you happen to miss them.
Yep.
Now I'll turn it back to Dr. Latta.
Yeah, absolutely. And so this is kind of the next step, which is how do we pull all of this together? Dr. Baker had talked about identification, and then we talked about treatment, kind of weighing risks and benefits, also risks and benefits of non-treatment, and doing shared decision-making with our patients. And so the collaborative care model is a really good way to pull this all together. How do we actually think about this in actual care when you don't have a psychiatrist that is in the office or right down the hallway? And the collaborative care model really focuses on the patient. It puts the patient right in the center of the model, and it encourages the elimination of what we call these silos in healthcare, where mental health care is separate from physical health or OBGYN health. And in putting these together and not treating them like two separate things where there's two separate homes of care, we can really assess for the overall patient's full needs and then make sure that they're getting their needs met in a integrated, coordinated fashion. And so we have networks that can provide outreach in innovative ways. This is especially helpful in locations where there's poor access to resources and when there's high needs for mental health. So let me pass this off to Dr. Baker. She'll dive into our first journal article and talk about our first model.
And so our first journal article was Key Elements of Integrated Perinatal Mental Health. And so it puts the patient right at the center, and we are bringing to the patient training and education, integrated care delivery. One of the things that we're doing at our center is actually implementing nurse navigators and doula care to really sort of work with the OB care team, the physicians, midwives, and other healthcare professionals to center the patient. And then, of course, there is the health component of this. We are taking care of a mom and baby throughout the pregnancy and postpartum period. So we want to promote healthy lifestyle and prevent any poor outcomes. And then transitioning and discharge planning. And so that's something that's very important as patients move through the spaces. Some folks we're seeing in the office, in the ambulatory setting, and then they're going into the hospital, having their birth, and then planning for discharge, and sort of making a plan for those patients who have had positive screens, who we know may have pre-existing mood disorders. We really want to focus on getting those patients back into care as soon as possible so that we're keeping an eye on what their needs may be. And of course, throughout this entire process, we're screening and assessing the patient and try to understand if there are mental health needs that we need to meet for that patient. And this is all the biopsychosocial approach that we have heard so much about. So we're taking care of their physical, their mental, and their social health as we work on that. And so these are the 7 key elements of integrated models of care. And so I think that the patient-centered approach is always best when we're respecting what that patient's needs are. We're meeting the patient where they are. This is, very key and critical to preventing poor maternal health outcomes and maternal mental health outcomes. Now we'll go back to Dr. Lada to talk a little bit about another collaborative opportunity.
Yeah, so the second journal article, Qualitative Examination of the Implementation of the Perinatal Collaborative Care Program, it really looks much more closely at workflow and what is an effective workflow and what is a model that focuses on bridging the gaps between OBGYN and psychiatry. And so in the middle of this model is a care manager. And so the care manager is directly connected to the patient through the OBGYN. So the OB might recognize there's a need or there might be a positive screen. And a care manager reaches out to the OB patient, is trained specifically in assessing for disorders, doing screens like PHQ-9s, GAD-7s, as well as EPDSs. And that care manager is then connected to a psychiatrist. And so the psychiatrist is able to weigh in on the patients that the care manager is managing in order to provide any psychiatric medication recommendations and in order to further guide care. And these recommendations are passed back to the OBGYN in order for them to evaluate and potentially implement those plans with their patients. And so it is a way of making the care manager really this pivotal person that is coordinating the patient's care, understanding the patient's care, making sure that there are no gaps, that nothing is getting slipped. And within that, a lot of these programs can utilize telehealth, which is what brings the end service to the patient. We are very lucky with, a lot of the innovation that's happened on the telehealth side that now even in poor access areas in rural care deserts and things like that within the states, we're able to utilize different resources from different part of the states to get our patients' needs met. So you may be listening and thinking, this is great, but you know your community and you know your resources. And sometimes these models can be difficult to set up, or it can be hard to find people in your community that do perinatal mental health. So Dr. Baker, I'm curious, since you have a lot of experience in this area, what should an OB do in this circumstance?
So, one of the things I work in a rural area, I've worked in rural areas pretty much since my entire career. And figuring out those resources can be a little daunting when you don't have psychiatry. I'm very, very pleased to announce that I have had a psychiatrist in town for the past 12 months. So that's been fantastic. But before that, I was really tapping into our state perinatal psychiatry access programs. And anytime that I found a patient who has a positive screen, I'm actually have access to these perinatal access programs, and these have been fantastic. Some states have set them up. There is a nice network of perinatal access programs through Postpartum Support International. And so what you're able to do with these is to be able to reach out to get help in terms of determining what your diagnosis is, what your treatment plan should be. So we're able to access those. And so these programs basically provide education to folks who are on the front line like me, who maybe are not psychiatrists or who don't have any special training in maternal mental health. They also can provide technical assistance to help us implement screening and treatment protocols in the event that we're just not sure how to translate those recommendations from ACOG for screening and brief referral to treatment. So they can help you set that up in your practice if you're looking to do that. They have consultation with psychiatrists for complex cases. I often avail myself of this consultation feature. You can actually call and, within a set period of time, usually pretty quickly, within 24 hours, you can talk to a psychiatrist who does have an interest in perinatal mental health. Many times reproductive psychiatrists staff these consultation lines, and you can actually get help, talk to them about your patient and say, okay, what should I do? I've even had consults where patients didn't need to be hospitalized, and they've helped me be able to facilitate that for my patient. And they also have long lists of resources and referrals that might not be available in your area, but are now accessible to patients because of our telehealth. So there are many support groups. There is individual counseling that's available now through telehealth. So there's so many advancements. And so I highly recommend checking out the Postpartum Support International website, and you can see resources for yourself and for your patients as well. So now I wanted to kind of talk through a real case with Dr. Latta. And Dr. Latta does serve as one of these psychiatric consultants that you can reach if you're calling PSI. So, Dr. Latta, what about the framework that we can use to structure these discussions?
Yep. So where we want to start off is with this ACOG presented framework for detection, assessment, treatment, and follow-up. So detection is always the first part. That is usually the place that putting the systematic screens and regularly scheduled screens is really important. We don't wait for people to come in with symptoms in order to screen them. The goal of the screens is to population level detect something that we know that is very common in the pregnant and postpartum population. Then doing an assessment that could be based off of the screen, asking further questions, understanding severity of symptoms, understanding how this is affecting someone's life, and then treatment and follow-up. This is part of the collaborative process. So treatment can start in the OBGYN office. It can start in the OB office with psychiatry input if needed. It could start with an OB leading into using a case manager in the collaborative care model that then loops in the patient, engages the patient in treatment while also getting the psychiatric resources on board to make sure that the treatment is being guided. And then there is follow-up both on the mental health side with the case manager and psychiatry following along, as well as follow up on the OBGYN side. So this is the general framework. But maybe what we can do just to deepen this a little bit is, Dr. Baker, come up, if you can share a case with us where you've utilized this framework and kind of what you saw happen, what went well, maybe what didn't go well, and give our viewers and our listeners just a little bit more detail about what this looks like in clinical practice.
So I think that this framework I've been able to put it in practice, and it has worked quite well for me. So there was a patient I had that was in her 30s who delivered a baby and found herself struggling with postpartum depression. So this was a highly productive professional person, just did not expect to find herself struggling. And she was actually not a patient of mine through her pregnancy, but she was a patient of my colleagues. And so they were screening using a validated screening tool and did detect that she was having some difficulty in terms of her mood and her functionality at home. And when she tried to go back to work, there were a lot of issues and problems. And so we have a collaborative care model in my system. And actually one of the nurse navigators who's a part of our nurse navigation program reached out to me and asked me if I would be willing to see this patient and try to take care of her postpartum. And so we did some additional assessments to kind of try to pinpoint where some of our issues were and what we thought treatment might look like for her. She was already on an SSRI, and we're kind of trying to figure out, what other adjunct things can we do. And so I was able to get her referred to a reproductive psychiatrist for telehealth appointments because she lived in a very rural area. And then she and I were also able to do telehealth appointments together as well. We added in some additional treatment. I tried a neuroactive steroid. We moved some things around with her SSRI. And then we were also able to get her into psychotherapy. So she was doing therapy, seeing the reproductive psychiatrist, and then following with me monthly. And so she was actually able to rise from that deep, dark hole that can be postpartum depression. She's back at work, highly functioning again. And so I think that when we put this into practice and we get the right help for people, then they're able to really thrive.
Yeah, I love that. I think that is exactly how things work in an ideal world with all the resources coming together. That was the detection, the assessment piece, the treatment piece, and the follow-up piece to make sure she was receiving all the care that she needed. And it sounds like she had a great outcome. Kind of thinking through a case from my side, since I work as a psychiatrist, a reproductive psychiatrist, and I'm taking care of patients often who are coming to me who are also seeing their OBGYN, I can go through a case where collaboration was very much needed and ended up happening, and also kind of the risks of it not happening. So there was a patient that I had been taking care of pre-pregnancy. She had a history of bipolar disorder, but had no manic symptoms for over a decade. And she ended up getting pregnant. She was on a mood stabilizer in addition to an SSRI. And, I had gone over risks and benefits with her in terms of the medication, as well as some of the things that we don't know about the medication, but had a very thorough discussion around potential risks of not treating with medication during pregnancy. And she went to her first OB appointment. And her OB was not familiar with the medications and was not very familiar with bipolar disorder, which makes sense because she's an OB and she doesn't treat bipolar disorder every day. And she actually reached out to me saying that, I see that we're both taking care of this patient. I'm concerned about these medications. Let's have a discussion, or can I get the copy of your last note just so we're both on the same page about what she's doing during pregnancy, and we can monitor together for any escalations and, coordinate care as needed. And that is like the perfect example of why this collaboration and coordination is so important, because, one of the medications she was on had a risk during pregnancy, and it might have been easy without that coordination for the OB to say, well, this is a risky medication. We need to go ahead and stop the medication, not necessarily working with the other side of things, which is that bipolar disorder untreated during pregnancy can be very dangerous. It can lead to higher, rates of not only depression and anxiety, but also psychosis and mania in the pregnancy and postpartum period. But through this collaboration, through the open communication, as well as connecting directly with the patient's permission, we were able to work together to make sure that she had all of her needs met. We monitored her symptoms. We've actually needed to increase medication as the patient came into the third trimester, which the OB then felt very comfortable doing and comfortable monitoring because we were working together on this case. And she went through pregnancy, had a postpartum period that did have some depression, but was actually pretty well controlled, did not have any mania, did not have any psychosis. Baby was healthy, mom was healthy, and she continues to do really well today. She's a patient I still see regularly, and I think it's a good example of detecting, assessing, collaborating, treating, and following up together.
Wow, I love that story because that really is what we have to do in order to make sure that our patients have the outcomes that we desire. I was at a conference week before last, and we were talking about maternal morbidity and mortality. And there's some new data that was released by the CDC that actually outlined that mental health and suicide and substance use were actually collectively responsible for close to 30% of maternal deaths. So it's the top cause. So I think many times we're very worried about medical comorbidities like hypertension or diabetes, and we're screening for all of these things very regularly. They're on our radar, but sometimes we are not screening for mental health disorders, and those can be just as deadly, if not more. So I encourage everyone who's watching or listening to please use those validated screening tools. Find a friend or make a new friend and call up that psychiatrist or psychologist who's working with your patient so that you can understand what this patient has been going through. I too have gotten patients that are on medications that I normally would not use in pregnancy, but because they're stable on those meds and they've been stable on them for years and years, we find a way to work it out together so that that patient is able to remain in good mental health throughout the pregnancy and postpartum period.
Dr. Baker, I just want to reiterate one thing that you said. This is kind of my soapbox moment, which I'm really glad that you've just brought attention to that very high rate of preventable death and morbidity, mortality related to mental health. Because I think sometimes when we think about mental health disorders, whether we're screening and treating or maybe not screening as often as we could, there is sometimes this idea that a postpartum mental health disorder is time limited and somewhat benign. And it is really important to recognize that these disorders are often not time limited if not treated, and they are anything but benign. They have very real consequences, certainly consequences that the CDC have now reported on. And so it is really important, just as we're paying attention to the physical health, just like hypertension during pregnancy is not benign and all those other sorts of things, optimization of mental health during pregnancy is the gift that we'll keep on giving if we're paying attention. So yeah, we can move into Q&A now.
Absolutely. I totally wholeheartedly agree.
Wonderful discussion there. And we thank you both, Dr. Baker and Dr. Latta. At this time, we'd like to invite the audience to submit any questions that you may have in the comments section of your format. But we can go ahead and start with a question that we received earlier. So we were asked, what role do family members or support persons play in the collaborative care model?
So I'm very happy to take a stab at that question, and feel free to jump in, Dr. Latta. But I live in a small town. I practice in a small town, and I get a lot of intel from family members and friends. In fact, just recently, someone texted me and said, "Hey, can you check on my loved one? Because they're just acting way out of character. I think something's wrong. I think they might have postpartum depression or anxiety." So I was able to, reach out to the patient, have my nurse get her scheduled with me for a telehealth visit just to lay eyes on her and talk to her. So I think families and friends actually play a very important role, because sometimes when we're acting a little out of character, we don't recognize it ourselves. Maybe we're very irritable. We're doing things that we would not normally do. So it is important for the folks surrounding us to be our village and to speak up about that. So I like to get that sort of intel, and then they also come play the role of support, right? So if you find that someone is having a mental health issue and they need help just, deciding to go in and be treated or seen, going with them, encouraging them, helping with the other physical needs that they have, like taking care of baby, letting them get a little bit more sleep, making sure they're eating well. Like, these are things that can be very helpful from families and friends, and just encouraging them to take good care of themselves.
Yeah, absolutely. I think the only thing that I'll add to that, Dr. Baker, is that, sometimes I think as healthcare professionals, we get nervous about the passage of information and consent and things like that. And it's very important to make sure that we're getting consent if we're giving out information. But in terms of taking in information, we're able to take in information from anyone who wants to share that with us, right? So if you have a mom that's coming in that maybe is a little bit reserved or seems like she's guarded, is not maybe sharing a ton of information, and if dad or husband or spouse, partner calls and leaves you information, you might not be able to call back and discuss that with them, but you can certainly take that information and allow it to influence your decision making and your outreach for your patient and things like that. So just wanted to point that out, that collaborative care and taking care of, the patient, all the resources that we can get our hands on, whether that's support, information, collateral, it's all useful.
Absolutely. Yeah, we are bound by some laws, some privacy laws, but I think getting that information and putting it to good use, you don't necessarily have to report back to the, well, unless you have permission, you should report back to the person who gave you the info, but get that info and check on that patient so that you can kind of see what's going on. So I think that that's a great way for family and friends to be involved.
Good
Do you have
answer.
any
Thank
other
you so
questions,
much.
Georgiana?
We do have one more question here. We have someone has asked, what strategies or how can you counsel patients in terms of overcoming reimbursement issues when you're trying to implement a collaborative care model or get them treatment for postpartum depression?
That's
Yeah,
a really good question.
I'm happy to take that one. So, in terms of traditional collaborative care and utilizing what we call the COCM codes, that definitely requires some foresight in terms of setting up, and it does require some billing knowledge in terms of billers sending off these codes and understanding what requirements need to be met in order for those codes to be covered. But it is a reimbursed model. CMS, directs reimbursement on these things. Most commercial plans, as well as Medicaid plans, also reimburse. Kind of like any billing query, it involves getting a knowledgeable biller, right? Understanding if there's denials coming back, why, and understanding what documentation needs to go in place in order to make the model work. But the way that the model is set up, the reason that these codes around the COCM model have been set up in that way is really to support the OBGYN or the primary care doctor in having a case manager on board to be able to take charge of some of the mental health things that are coming up, with a psychiatrist that can lean in and do population management and really take care of a lot more patients than a psychiatrist can take care of one-on-one. So that's what I would say for the collaborative care model. And I think just in general around postpartum depression and patients going and seeking treatment, that is usually individual to plans, right? What they're going to cover on the behavioral health side, whether they will cover therapy, how much therapy they will cover. But by and large, plans are motivated, health insurance plans are motivated to address these things quickly, to address them effectively, they have the information and the knowledge that not treating these things is not in their best interest. It's certainly not in the patient's best interest, but financially is very costly. And so to make a general statement, more and more of what we're seeing is that there are often pregnancy and postpartum benefits that will cover therapy without a copay. And if there are copays and things like that, there might be ways to check in with the insurance and see how that can be negotiated. But I would not want, and hopefully when you hear your patients say, like, I'm not sure that I can afford it, or I'm not sure that my insurance will cover it, the next step is always just go and get the data, go run the insurance, go have them see a therapist who can give them, an idea of what they might be responsible for, because sometimes we have ideas that things won't be covered or that they will be more expensive than they need to be, but oftentimes, especially in the postpartum period, insurance is covering mental health treatment.
Great information. Thank you for sharing and educating all of us on that. So we're going to go ahead here and go to our overall takeaways. And Dr. Baker, I'm going to give you the final word today before I review the CE information with our audience.
Well, thank you. This has been a fantastic series, and I'm so glad that we had a chance to have these great conversations. And our overall takeaways is that the collaborative care models actually increase the likelihood that patients are going to be screened and treated for postpartum depression. And so a collaborative approach always helps us better address patients' mental health needs and really all healthcare needs, honestly. Medicine has become a team sport. And so I just want to encourage everyone who's listening or viewing to make sure that they're screening their patients, that they have a plan for how they will assess their patients if they screen positive, and how they're going to refer that patient for treatment or start treatment themselves. So thank you guys so much for watching. We hope that this has been helpful to you as you are on the front lines taking care of patients.
Excellent information, and I would echo everything Dr. Baker said. To receive credit for today's presentation, please scan the QR code to complete the evaluation. The link can also be found in the comments section, and upon completion of the evaluation, you will be able to download your CE certificate. We just want to thank our audience and a big thank you to our faculty for this important information that's been shared throughout these three conversations. We hope that everyone has a pleasant evening. And again, thank you for joining us.